Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. How are you?
Good, you look awfully dressed up.
Well, I thank you. So do you.
I very rarely wear a tie nowadays, and it's just I feel like I've worn one like, way more than usual. So why are you all dressed up today?
It's funny you say that first part about wearing it more than usual. I have as well. I've had just a number of special occasions. Today was a really special occasion. We had our annual fellowship interview day.
Yes, we did. We welcomed 32 of the best and brightest hand surgery candidates to St. Louis on a very typical warm, sunny spring day in St. Louis. Somehow we got beautiful weather for an early March interview.
Yeah, I mean, I don't know which hand fellow applicants we did not have a chance to see, but wow, what an impressive group of future hand surgeons. Makes me feel really optimistic about the future of hand surgery.
Yeah, no, to your point, I mean, I wish that we could have met everybody in the applicant pool, but I think our partners have a very limited capacity for interviewing a number of people, and I think we did about as many as we could today.
It always makes me astounded by Peter Stern at Cincinnati's approach, where you would come in and spend a half a day with him, and he would do that for 4 to 5 months. And every Monday and Thursday, there'd be one or two candidates, and he met far more than 32. But what a commitment. I mean, my goodness.
Yeah, I remember my interview very well. I interviewed with two other people, and you're basically in the fellowship for a day, which was a really cool way to see it. I mean, you went from conference to his surgery center and observing surgery behind him and being in the Socratic method of teaching. And I actually retold that story to one applicant today. And it's a different vibe, but you do understand what you're getting into.
You do, and you did. Dr. Stern is an amazingly nice human being, but he does ask you questions. He used to, obviously, when he was doing this, ask questions in the OR, and I struck out. I missed the question, so that didn't do me. I still ended up there, but it was kind of funny.
I did strike out as well, so you're in good company, and I didn't get the fellowship, so maybe it doomed me.
Too funny. These days are long, and I'm glad both of us have the energy to do the podcast recording afterwards because I think they do energize me. I mean, it really some of the stories and the energy, it's just really something. So I really enjoyed today.
There are some incredible people. Their paths to becoming a doctor, to becoming an orthopedic or plastic surgery resident, and what brought them to being a hand surgeon is really inspiring. And it is very much so energizing and affirming. And really, we're fortunate to get the chance to talk to these people and talk to them about our fellowship. So we appreciate everybody who came in, and thank you to those of you that gave some podcast love.
Yeah, absolutely. We always appreciate it. As we said, it is our fuel to keep this show on the road, so to speak. There is a little bit of a change of format coming, just as a little early warning. This episode, I think, will drop in a week or so, and then we are going to be helping promote the IFSSH annual meeting in Washington, D.C. at the end of March. So we will have podcasts for probably 4 days in a row or something like that, short promotional podcasts. So I apologize to those of you who are listeners that won't be there. It'll be fun. Wee Lam is an amazing hand surgeon currently in Singapore who has a lot to offer. So he and I will be having fun while Chris celebrates on the beaches of, where is it, Thailand? Where are you going?
Oh, why you gotta blow me up like that? No, so I had IFSSH on the family calendar well in advance, like seriously, 13 months in advance. I had it on the family calendar. The family calendar is sacrosanct, apparently for only some in the family. Because once my wife got to planning, she sort of overlooked the fact that we were supposed to be somewhere else for that week. But I will miss you. We is a wonderful, will be a wonderful guest host, and he's a way better accent than I do.
At least true on the last point, but I'm happy for you and your family and wish you safe travels. And I'll be in DC. DC is an amazing place and the cherry blossoms will be great. It's not a number one city to visit in early 2025, but
Hey, hey, now, easy, easy. It's a beautiful city, great restaurants, a lot of fun things to do, regardless of the current environment. The standard American classics are there, Smithsonian, the monuments. It's an amazing place.
Yeah, actually, one of the things I'm looking forward to, not to go down this path too far, is the portrait gallery, which I have not been to in DC, and that is the site of the gala on Thursday evening. So that'll be super fun.
I think that you will have a wonderful time.
I will. Hey, Chris, the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
Nice, nice.
Such a smooth segue into the copy.
I know. The listeners are not going to believe this, but I recommended that we talk about nerve today.
Yeah, it was so weird. You came up to me yesterday saying that you wanted to talk about nerve, and I almost thought I had like a stroke or like a seizure or something. Like it was a welcome adjustment. So thank you for welcoming this into your day.
Don't get used
But
to it.
I did let you pick the nerve topic. I actually came up with a few while I was working out this morning, and then I never got to text you, so you beat me to the punch.
Well, you'll have to save those. I also got up early and worked out this morning because I knew if I came up at the end of the day, I may go outside and enjoy the weather, but I knew I wouldn't work out.
Well, my wife, Tiffany, kindly asked what we would be doing tonight, and I told her I'm going to be essentially useless when I get home because I will be so tired from a day of interviewing and now podcast, and I have a stack of administrative things I have to clean up before I leave the office because they won't get done once I get home. But I told her I'd be pretty much useless when I got home.
Yes, yes, indeed. So why don't I, unless you want to talk about anything else before we jump to the case, I can present a case scenario to you.
Yeah, that'd be great. I will say it was nice to have a few listeners come in and mention the podcast during the interview, talk about how they've been listening to it for years, and how it was weird to hear us talk at 1x speed.
Yes, maybe I heard the same thing you did from the same person, but it still made it good.
Exactly.
I've
You know
been
who you are.
I have been using the term edutainment because I think that is the category we fall in, which really does distinguish what we're trying to do from other podcasts because we do hope we are entertaining and we do hope we are educational.
You're an entertainer, Chuck. You're entertaining and an entertainer.
You don't have to laugh with us. It's okay to laugh at us. My wife does.
So tell me what you got.
All right, and I think we can vary the demographic parameters, which may vary our approaches to this. But let's start with a young man, maybe 54 years of age, who is in let's say that person is riding their bicycle, hits a pothole, thrown off the bike, and sustains a spiral midshaft humerus fracture with an accompanying radial nerve deficit. And you're seeing them in the clinic for the first time, they're in a sling. I would just love to know what goes through your head, how you manage them, how you work them up, and what your time frames are.
And I think that you put a lot of variables in there that could certainly change how we manage things. So the patient's already, I'm seeing them in the clinic. I don't know if they've seen anybody from orthopedic trauma yet. You mentioned they've already got a diagnosed nerve palsy. I don't know what the ultimate treatment plan is going to be for the humeral shaft fracture.
Yeah, I can share that. Let's
Yeah.
say they went to urgent care and they were told that they do have a spiral humerus fracture. It's an acceptable alignment. Despite your specialization, you do look at the X-ray and you agree that the humerus fracture does not need surgical intervention. And you find, your exam would be interesting, but you find there is a dense radial nerve palsy.
So I guess I don't know at this point, like where the orthopedic trauma literature is in terms of how much angulation is okay to accept. I remember putting on a lot of coaptation splints as a resident, and I think that those types of splints probably still have a role in treatment. I think that if somebody were to consider treating it surgically, I think that would change the management, and then also the location of that fracture might change management too, whether it's truly shaft or distal third. Um, I think on the exam. I think getting a Tennel sign is probably not going to be reliable given the amount of soft tissue swelling and tenderness around the bone. So I probably wouldn't go so far as to look for a Tennell's. I think you start by looking at triceps function, which also might be limited by the bony trauma, but just getting a sense of how robust it is. Um, and then the standard series of wrist extension, looking at thumb extension, making sure that you're not looking at any thumb motion that's coming from the intrinsics or the long flexors, and really isolating the first and third compartments. And then looking at the EDCs and making sure any finger extension is coming through the EDCs and not through the intrinsics.
So really good stuff. And we can delve into directions about surgery, non-surgery, all that. But at this point, let's say non-surgical. And let's be honest, the exam is pretty straightforward if there's a dense radial nerve palsy. But to your point, how do you check for EDC function first? I check it by simply asking the patient to make a fist, which should be intact, and asking them to extend their MPs with their IPs flexed. Do you do anything different?
No, I think that's great. I do the exact same thing, and then I check if they can do that. I check against a little bit of resistance. It's always good to have a baseline of their contralateral MP joint, compliance, so to say, because most people hyperextend, but some people just don't. So you want to make sure what their true anti-gravity full arc of motion is before you chalk up any deficits. And then, I think sometimes a Tinel sign over the superficial radial nerve at the fascia lexus, just proximal to the radial styloid, can be useful, but usually a little later on, not so much in the early exam, unless there's any concomitant forearm injury, which it sounds like there's not in this case.
Not in this case, right. And just to be clear for our younger listeners, we want to take out the ulnar nerve in assessing the radial nerve. That's why we're taking out extension of the IEP joints, which is usually intrinsic. And then lastly, you mentioned the thumb, and then we can get fooled on the thumb because
Mhm.
you can use your median nerve innervated muscles to extend the thumb MP and seemingly IP joint. So you really have to see true retropulsion of the thumb. I think the easiest way to do that is asking the patient to take their hand, which is flat on the table, and pull the thumb off the table. Do you have any other tricks?
Same thing, and I use that in the context of a distal radius fracture. Usually it's the minimally displaced ones. You're looking to make sure there isn't a nutritional rupture of the EPL. No other tricks. I think also, kind of the nerve nerdy stuff is differentiating the MP extension from the EPB, from the IP joint extension from the EPL, which matters somewhat in the sense of when you're looking at tendon and nerve transfer options. For the purposes of getting a prognosis on this lesion right now, I don't think it matters.
Okay. So you're hearkening back to your HSS residency days, and you say, look, I think you look good. I know you've been comfortable in this thing. I'm going to put you in a coaptation splint, which is great. Those are well tolerated and plus minus a sling, whatever is the patient's comfort level. What do you do with the wrist? Do you give them a cock-up wrist splint on that first clinic visit, or do you just leave them be?
I think the easiest thing is the cock up wrist brace, so a prefab. If it fits them well, I think that's a really good tool. They're probably going to be better off if they can get to a hand therapist and get something else made. Sometimes a Benic, which is a something that you can actually buy online and then kind of get warmed and molded to you, can be very useful, provide that MP joint support. But at the very least, nobody likes having their wrist kind of drop down. So having something to just keep it up is very useful and just more comfortable, to be honest with you. You've already got a big coaptation splint and a sling on. So
Perfect, perfect. And then patient seems good. You feel comfortable with where we are. When do you see them back to presumably examine them again, or when do you consider additional testing?
yeah, so I mean, I think you're describing we're seeing somebody pretty early on, and I think the concern for a transection injury is pretty low. It's not the lowest mechanism of injury in terms of velocity, but it's still probably on the lower side of the spectrum. So I'm comfortable not getting any additional testing initially and doing a repeat exam in 4 to 6 weeks. I wonder about the role of ultrasound here, just because, we have seen some transection type injuries from more, like say it was, for example, it was from an MDC, or for sure if there is a ballistic component, then we would be looking at an ultrasound, just because the higher velocity injuries tend to have a higher risk for actual partial transection or complete transection of the nerve. How do you think about it?
Yeah, and I think we're both saying, someone else may be taking care of the fracture. I think in my hands, I might be taking care of the fracture as well, especially in the adolescent population. I certainly could be. So in that case, I'd probably see him back at, 2 weeks, check an X-ray for a bony alignment, make sure we're not losing ground, re-examine, although I wouldn't expect radial nerve function to significantly improve. And I think for the first 6 weeks, I'm okay with that approach. I haven't found ultrasound particularly helpful. I think it's reasonable. Certainly, in your hands, it's reasonable. but I would also plan a reassessment at 6 weeks to sort of see where we are and consider testing, whether that be imaging and or nerve studies if there's no evidence of recovery.
Yeah, I mean, I think that we're still trying to feel out the role of ultrasound early on. I'm more apt to get it because I think it does provide some complementary information, especially in that first 3 to 4 weeks before you start to see findings on your electrodiagnostic studies, because you have this 3 to 4 week period before the Wallerian degeneration starts to kick in and before you see the denervation findings on the EMG, where maybe there's some additional information that could be gleaned from an ultrasound early on. But I still think we're in the early phases of using that and feeling that out. I actually spent the majority of the last month turning in a grant that went in this week to look at that exact role of ultrasound and biomarkers early on for traumatic nerve injury to see if we can prognose earlier if this injury is going to get better. Odds are this is the kind of injury that you're describing that has the best chances of getting better. But not everything follows the textbook, as you know.
Yeah, in preparation for this podcast, I spent a lot of time boning up on nerve injuries. Just kidding, but I did find an interesting article in the journal Curious, which I think is a high impact open access journal from Hegeman is the first author, and this is from it's an Army Uniform Services manuscript, and it is a the title is Incidence and Management. I'll put it in the show notes. Incidence and Management of Radial Nerve Palsies and Humeral Shaft Fractures, a systematic review. I did find it to be well done. And the data is interesting if you don't mind my sharing. So 4,900 humeral shaft fractures, 12% primary radial nerve palsies. During exploration, no neurologic intervention was performed for 41% of those. And the most common finding was no evidence of nerve lesions. So those who underwent neurolysis were more likely to resolve compared to primary nerve repair or nerve grafting, but very high rate of spontaneous radial nerve recovery at 85% with the nerve exploration. Now, I don't think the nerve exploration is is the explanation, but again, not, these type of studies are not definitive, but how do you think about that?
Yeah, I mean, I've done a number of systematic reviews and meta-analyses, and I'm always cautious with performing and interpreting these because, when you look at the literature in this way and you try to do a pooled analysis, for lack of a better term, it's garbage in, garbage out. And for our friends across the pond, rubbish in, rubbish out. So, if you try to pull these studies together with all the heterogeneity that's involved in how the samples were collected, how the samples were analyzed, a lot of times you don't have individual data like a table like per patient, and you're pooling together results that have already been pooled. It gets quite messy. I think the message here is helpful though overall. It just depends on, I don't know how accurate some of these percentages are, but what I take away from it is that there's a real risk of having a radial nerve palsy after humeral shaft fracture, probably more than 1 in 10. It's helpful for counseling. So when somebody comes in with this, say like, this is a pretty relatively common thing that can happen. So just keep that in mind. There's nothing different about you in particular. Most of the times they do better without surgery. And if something is typically doing better with a neurolysis, to be honest with you, they probably would have done better without it. And that's as a skeptical nerve surgeon. And the fact that the people who had a neurolysis do better than those with primary repair or nerve grafting is probably more of a reflection of the severity of the initial nerve injury. So I think this kind of review has a role, and it provides some important lessons, particularly just giving you numbers to counsel patients with. But I don't think it's the end all be all, but it is super helpful to have as a touch point.
Okay, let's go back to our case. And let's say you do an ultrasound at I don't know what time frame, but the nerve looks okay. No obvious nerve lesion, nerve's intact,
Not
nerve's
entrapped in a fracture, which is the other thing that can happen sometimes.
not entrapped in the fracture. So now we're at 6 weeks, or you can say 8 weeks, no nerve recovery, no tenels. Do you obtain a nerve study, and would you consider a nerve study sooner?
I like the nerve test at 6 weeks. Mainly it's as we've joked before, one orthopedic unit since the injury. But it does give enough time for Wallerian degeneration to clear itself. If I really wanted to be precise, I probably will get one at 4 weeks. Um, but typically, we're not going to do anything about surgical intervention in this context until about at least 3 months. So if you had to hold my feet to the fire and say, when do you really need a nerve study? Probably 3 months. The 6 week study is nice for context and for comparison and counseling. But if you're in a resource-strapped environment, the patient can't come in, et cetera, or you don't have access in terms of you can't get them on the schedule, the 3 month one is the one that matters the most. So if you're in that jam, if you've got them at 10 weeks, I probably just wait until the 3 month mark, as opposed to pushing to get a serial study, doing it more than you need to.
Okay, makes sense. So let's
How do you
say,
think about it as a non-nerve specialist? I mean, I know that the teaching might have been different in the past, and your experience recently may have also changed.
yeah, just call me old. I like how you slipped that in. I would probably get a nerve study, depending on the patient and the patient need for information, the patient's patience. I might get a nerve study at 6 weeks to have a sense, but to your point, then if I repeat a nerve study at 3 months, it gives me a sense of directionality. But obviously, I agree with what you laid out.
Does it matter with the age? Like you mentioned this was a 54-year-old patient, but you also mentioned you treat a lot of adolescents. So do you think that an adolescent would tolerate more nerve studies than you need?
No, 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 I definitely do not. I think that my expectations for nerve recovery are higher in the adolescent. And the second piece is how I think about surgical intervention might be different
Hmm.
in an adolescent. And for example, an earlier pronator teres to ECRB might make sense for an active adolescent, although I certainly am
Hmm.
not advocating for an early tendon transfer necessarily.
I hear you. Okay. All right.
So we're at 3 months. What would you see on a nerve study that would make you recommend surgical intervention?
So I think to preface this, we have a lot of dogma in nerve surgery teaching that 3 months is the study that you go off of. Like that's the threshold in which if you don't see any motor units on your nerve test, uh, in the muscles of interest, then it's probably not going to recover. Now, I'm not sure exactly where that 3 month teaching came from, and I've looked a pretty good amount. And if any listener can point me to the primary article for that, or at least the primary teaching, even if it's not from a case series or whatnot, I'd be really appreciative because I do want to understand that a bit more, but we all tend to use 3 months. Um, Now, that being said, in this particular context of a radial nerve palsy, there are a couple of really good papers showing that the absence of CMAPs and the absence of robust motor units at 3.5 to 4 months is predictive of the radial nerve not coming back. So there's been data to support this dogmatic belief, which is helpful, but I'd love to see more. So when I'm to answer your question, I'm looking in the muscles that they're checking. They're probably going to check the triceps, which I would expect to see some recovery because triceps often gets innervated proximal to the level of the shaft. As well as sometimes they'll get the BR, although it's not essential. It's useful to see because that's going to be our first muscle that's innervated off of the radial nerve about the elbow. And then I would say to look at the ECRL/ECRB. It's very hard to differentiate, to be honest with you, from a sonographer or from a electrodiagnostician who's probably using surface landmarks. If they're using ultrasound, it's much easier to get to. But I kind of group them both together and start to look and see if you see any recovery of motor units in those muscles.
Okay, perfect. So it's now 3 months, 14 weeks, and let's say there is no motor recovery distally from BR on down. I'd like to know how you think about surgical intervention, i.e., what are you going to do? And also, I'd like you to share your experience with what you're going to do and how happy you are with it. Is this a home run intervention? Is this a double, if to use baseball parlance, since we're now in spring training?
Okay. Well, first, I will mention that the upper hand is sponsored by Checkpoint Surgical. As a hand surgeon, you know that nerves matter. It's why Checkpoint Surgical is singularly focused on elevating the clinical practice of peripheral nerve surgery with innovative technologies that help improve patient outcomes.
Checkpoint Surgical's portfolio includes a range of handheld intraoperative nerve stimulators, nerve cutting instruments, and biomaterials. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery.
I was reminded of that because I think it actually is relevant to what we're going to talk about next. But I think that at 3 months, you do have a good conversation with the patient. And you try to suss out. This is where I love collaborating with our hand therapy colleagues because they at this point typically have a really good sense of the patient, their goals, their expectations, their timeline. If this is the patient who we've been hearing from day one and the subsequent visits that they need to get back to work ASAP, then I think you're probably more in the tendon transfer category unless they have a high dexterity job and they're doing a lot of keyboarding. I don't think you need necessarily to do anything from a nerve perspective if all they want to do is get back to doing those kind of gross activities right away for wrist and finger extension. Pain is the wild card. Let's assume for now that they don't have a lot of neuropathic pain associated with their radial nerve injury. So I like to incorporate the therapist. I'd love your thoughts on how you talk to patients about this, but really trying to see like what's their timeline because that'll help. I can prognose your nerve injury. Doesn't necessarily mean that we need to intervene for a nerve that is not going to recover spontaneously or will take a very long time because there are lots of options. Now we can have a conversation about the different options, whether that's observation, tendon transfers now, or observation with tendon transfers later, or looking at pivoting towards a nerve transfer type strategy. And that's the one that is clearly time limited.
And be specific on the time limit. What's your
We honestly, we don't know. We think within 6 months is ideal. Within 9 months is okay, but not ideal. Within a year, you're kind of pushing it. That is also kind of based on dogma. There's a lot of literature, at least in the animal models, to support that early the onset for denervation-related atrophy, but we don't quite know exactly how long it takes to happen in humans and whether it's kind of a gradual downslope before you're not able to reinnervate that muscle or whether you just fall off a cliff. And that's still information that we need to learn.
Yeah, I think that's well said. Yeah, for our international colleagues, I will say in the United States, the Midwest is considered, and I think accurately, a place where patients may, I'm using this twice again, where our patients may have more tolerance and more patience for recovery compared to similar
Those demanding
situations,
coastal patients
those
on the East
demanding
Coast and West Coast.
coastal patients. I think that there's truth to that, but having said all that, patients want something done often. And I think we can put someone off for 3 months, ask them to just, sit tight. But at some point, 3 months, it gets harder and harder after 3 months, in my experience. And maybe if we haven't seen anything by 4 months, I'm almost always acting.
Yeah, I think that's good, and I'll send you a couple of papers that I have in my radial nerve talk that talk about kind of the nerve studies at 3 or 4 months and how that predicts prognosis because it's useful to have that information for counseling. And you say, look, it's this, these are your odds. You can leave it be, or you can do something. And are you looking for the nerve transfer thing that might provide a higher level of function? But will take longer. Will take the better part of a year, and if not more, for rehab to work. Has a slightly lower success rate, at least based on the limited series that we've seen. It's not as reliable as a tendon transfer. Or do you want the tendon transfer, which is a tried and true option that has probably a bit of a functional ceiling to it, but that functional ceiling is more than enough for most people and is highly reliable and is less intense in terms of therapy.
Yeah, all really well said. And I don't have any nerve transfer experience for this situation. And so my tried and true are tendon transfers. And I agree how you said that. I think they are reliable tendon transfers. I'd love to hear your favorite. They are reliable tendon transfers, and but they're not perfect. They don't recreate um, you know, status from pre-injury. And you are robbing Peter to pay Paul, so to speak. So I really like the option, but it's not perfect.
Yeah, so I mean, I know that your interest in nerve has a certain time limit, so we'll try to draw things to a close here. We did an interesting paper in which we did a qualitative interviews with a number of my patients and Dr. Mackinnon's patients, and really asking them kind of their experience with the decision-making process for treatment of radial nerve injuries, and that included nerve and tendon transfers. A couple of takeaways there, and one major one was that the patients really look at the hand therapist as their main conduit of information, and they talk to the hand therapist way more. They trust them. a really big amount. And the counseling oftentimes will come from the hand therapist. So the hand therapist play a critical role in this. And it really is trying to manage the expectations and the timeline. And that paper was in JBJS a few years ago. It was nice to see that our patients understood what we were telling them, but it was humbling to know that they really relied on somebody else for that information. That being said, I agree. I think the experience I've had with tenant transfers, they are very reliable. They have a limited ceiling with what they can do. When a nerve transfer works and it works well, it far exceeds the functional abilities, specifically with things like trying to get the fingers up independently. So keyboarding, playing the piano, for example, playing any sort of instrument, anything that involves more dexterity. And hopefully you've gotten clued into what their requirements for a job are and their desired activities are to try to get that to them. But that nerve transfer takes a long time. Even though you're really close distance target wise, it still takes the better part of 6 to 7 months to start to see your M1 activity. So that is the challenge here is that you put people through a lot in terms of timing. And then, so if you already made them wait 3 to 4 months, or you make them wait 6 months and then you put them in the nerve transfer pool, you've just wasted a lot of time potentially, which is why we're trying to figure out ways to prognose this injury sooner. So if you're going to go down the nerve transfer route, you're doing it at 6 weeks as opposed to 6 months.
Yeah, so that's all contingent on an early, honest conversation about expectations and needs for, as you said, a professional musician may be very different than a manual laborer for the needs and expectations. I like that. Um, so let's quickly talk about tendon transfers. What is your mix? What do you do? What's your favorite?
Um, so assuming the median and ulnar nerves are okay,
Hmm.
I really like a PT to ECRB tendon transfer, and I honestly will do that with my nerve transfers too, but that's the baseline. I think that's a very reliable tendon transfer that will keep their wrist in a comfortable position and will enable them to get out of any sort of forearm-based orthosis. So that is a nice one. Um, I like if we have palmaris longus, I like using that for EPL. I'm assuming we have our FCR in play, and I like using that for EDC. The trick sometimes is finding something we can do for EPB, and I think that's more challenging. Some people say if you got IP, why does the MP joint matter? Patients don't like that lag, and I think that's a real concern to the point where I've considered maybe even PL to EPB, and doing something else for the thumb IP in the future.
Yeah, I like that. I've never done anything for EPB. I'm not saying it, anything negatively about it, but I've just not personally done it. But I agree. That's my treatment of choice, and there are all kind of other options, including FDS and et cetera, depending on what's available, what's not. But there's no question that the pronator teres to ECRB is the key driver of success here. So I
So
like
I'm
that.
going to propose one thing here for you, Chuck.
Please do.
We should do a second part of this episode, specifically on the nerve transfers. And we can
Okay.
do it after all the IFSH is quieted down, and then we can talk about kind of the decision making, the intraop pearls. So I think that's what people really want.
A
They
whole
really want,
episode, though?
they really want that. That's what they want.
So this is going to be radial nerve palsy part one, and then you're going to have to
Mm-hmm.
wait a month for
You see
part
how I
two.
flipped that on you? You said you would tolerate one nerve episode, and I turned it into two.
All right, well then we're going to have to do a sports episode to follow because, people value sports over nerves, so we got to
I
give them
had
what
a
they want.
I had a great question today from an applicant who asked what the mix of my practice is. How much is nerve? How much is general hand surgery? And I told them the mix based on basically the days of the week. And they're like, that makes a lot of sense. He's like, you speak very knowledgeably about nerve, but you know a lot about other general hand surgery topics. So I said, thank you. It's because I
Wow,
do a lot of that too. So
that's high praise.
I know I love it. I love it.
All right. Well, then let's bring this to a close. And let me just say one other thing. If your trauma partner is exploring and repairing that humerus fracture, do you ask to be there? I mean, is it based on convenience, or how do you think about that with a dense nerve palsy and a displaced humerus fracture that needs fixing?
Well, I think that's a great question. I think it depends on the mechanism. Is it a mechanism where I'm more concerned about a transection or ballistic type injury? Then yes, I want to be there. Not that I'm going to do anything right then and there, but I'm more likely going to tag things and suture them to fascia so that they don't retract. And I want to know where things are relative to their plate or their nail or whatever. if it's a low energy mechanism, I don't necessarily need to be there. We are blessed with very great trauma partners who will go explore the radial nerve and will put in their op notes where it is relative to their construct with between which holes and what it looked like. Very useful.
Yeah. And I also think that there's enough of us hand surgeons around that rarely would you have to cancel a day to be available for the trauma surgeon, which is also a nice convenience. So that's
Oh, super
helpful.
helpful. And
Yeah.
then, when we talk about our nerve transfers, we should also talk about the role of nerve exploration and grafting in the brachium. Because Jaime Bertelli had a nice series in a more adolescent population showing the role of that surgery. So we shouldn't exclude the more proximal working at the site of injury surgeries just for the newer and sexier nerve transfers. So
Couldn't agree more because I can do option A, but not option B.
I
All
can
right.
I would love to see you harvest sural nerve. I think that would be amazing.
Oh, that's super fun. All right. All right. This was fun.
I hope
Thank
you
you
enjoyed.
for sure. And
If you made it this far and you're still listening, if there are other topics you want us to discuss, we're due for a sports topic, so please email hiddenpodcast@gmail.com or leave it in a 5-star review.
love it. All right. Thank you again for today.
All right, thank you.